We are going to be talking about an exciting breakthrough today on Must Know People. I got a text about a week ago from Dr. Suzanne Feigofsky, who was with us last season on Must Know People, about a great procedure that is now being performed here in Carroll at St. Anthony Regional Hospital. And we're so happy that she's available for us now. So Dr. Suzanne Feigofsky, she is an electrophysiologist. Did I say it right?
You did.
I've been practicing saying that too. So I would say cardiologist, but you say electrophysiologist.
I do both here. Yeah.
Okay.
But the electrophysiology part is the part that I'm using for this new technology.
See, I went back and listened to our first podcast, and I know that means you're the electrician of the heart.
Not the plumber.
Not the plumber. They're the guys that do the stents.
Yes.
First of all, you were very excited to perform a procedure here in Carroll. Let's tell everybody what that procedure was.
It was a leadless pacemaker, which is revolutionary technology, probably the way of the future. And I believe we've done this here. It would be the only critical access hospital where this is being performed, which is incredibly exciting. I want to bring the technology that I'm capable of performing into our community and to be able to do it safely. And the fact that we were able to do that is incredibly exciting.
Now, you mentioned this hospital is classified as a, what again?
Critical access hospital.
What's the difference between critical access and, say, like University of Iowa hospitals, Des Moines hospitals?
Well, those are larger hospitals, generally level 1 or level 2 trauma centers that have a multitude of specialty services, including surgeons, infectious disease specialists, et cetera. And with a critical access hospital, we're a hospital that doesn't have those facilities. And so generally, it's a hospital where you get a patient, stabilize a patient, and send them to a larger facility if they need it. Generally, less sick patients where length of stay is 3 days or less. And that status changed about a year ago. And so being able to still bring technology that is performed in larger cities to a smaller community is something that I've been passionate about since I moved here in 2014.
And that's something I think that St. Anthony's has really done a great job with, is providing a lot more services than any other critical access hospital.
Absolutely.
Am I right about that?
You are. And one of the reasons I'm so proud to work here is I think our quality of physicians is exceptional. I feel that our surgical colleagues are extraordinary. Our hospital family medicine physicians are also outstanding. And so we have a network of physicians and nurses and OR staff who can support me with the procedures that I'm bringing to our community. So it's not just about my skill set. It's about everyone at this hospital being able to provide the support that I would need to have a good outcome.
You said this is groundbreaking.
For me.
For this hospital.
It is.
And for you,
and for
too.
the hospital, yes, absolutely.
So what makes it so groundbreaking? Why are these procedures not being done in these types of hospitals?
There's several reasons. One is we have the ability to have anesthesia services. So these patients really need to be under anesthesia to be still. The difference, the traditional pacemaker is what we call a transvenous system. So it goes through the vein, under the collarbone, with the wires going into the heart, and then we create a pocket on top of the pec muscle under the skin on the chest wall. This is unique in that the entire device is self-contained. It's about the size of a third of a AAA battery. It looks like a fishing hook a little bit.
Almost like a .22 caliber bullet. Yeah.
I wouldn't know about that, but that's what I've been told. And it's implanted through the groin, so a vein in the groin. And then we have a very long sheath that helps us deliver it directly into the heart, and we implant it into the heart muscle. And then there's nothing external. The risk of infection is much lower. The battery life is longer. And generally, the procedure is much safer. It's just getting the skills to be able to do that safely. I think as a cardiologist and electrophysiologist, the sheaths and catheters we use are smaller than the size of this one to deliver the device. And that was a little intimidating for me to bring that here. So I worked closely with Dr. Abraham. The ones that we did last week were on a day where he was available in case I had any issues. And making sure that our x-ray techs were capable and familiar of what we were going to do. So Medtronic, who's the company that created this device, did come and train our entire OR before we did it. So everyone was very well prepared.
It's an incredibly complex procedure, isn't it? How long did it take you to get accustomed to doing this type of procedure?
You have to go through a training and pass the training to be certified. So that was a 2-day experience, if I remember correctly. And then you do practice on a live pig, which was interesting. The pig anatomy is similar. The heart is similar to a human heart. Mm-hmm. And then I did a few cases at Mary Greeley where there was a little bit more support staff. And I would say I'm still nervous doing them, but I also feel confident in my skills and being able to bring them here. I remember when I came here, the first thing Iowa Heart said to me was, you can bring pacemakers to this community, but don't kill anybody. And so,
good advice, guys.
Yeah.
Good advice.
So I wanted to bring this new technology with that same thought in the back of my head. So patient selection was very careful. And it just so happened, we had originally intended to do one procedure that I had planned a month ahead of time to give everybody time to get all the tools we needed. And then coincidentally, 2 others happened to fall in my lap around the same time. So it was great to be able to do 3 in one day, which helped get many people familiar with the procedure and comfortable with it.
So if there was 3 that you did the first day, there's no telling how many people out there are going to benefit in the future from this.
Oh, yeah. I would say in the last year, and I'm sure anyone in the OR would also agree that there have been cases where I've put in pacemakers and I would say, this would be a great micra. This would be a great micra. Mm-hmm. And it was just getting all of the parts in motion to make sure that we could do it here. And now that we have done it, I think the volume will certainly increase.
Now, how long did you take in preparing to do this? You said months. You were preparing 4 months to get normalized with this procedure, right?
Yes. It's not just about doing the procedure. It's making sure we have the right tools in the OR. So different than a cath lab, which generally has a lot of these wires on the shelf, these are things that are not traditionally done in our OR. So making sure we have the right tools available, that people are familiar with using the tools. Then there's the financials of it, making sure that the hospital can bill correctly for it. There's all sorts of things involved above my pay grade that I don't understand. Making sure we can recover the patient safely, changing the order sets because the access is different and the recovery is different. There's a lot of things we don't have to do that we had to do with traditional pacemakers.
Is this a less complicated procedure than doing the one where you have to actually implant the pacemaker itself up near the collarbone?
Yeah, it is. It's really just getting access to the vein in the groin, the femoral vein, getting the sheath up into the heart, and then correctly placing the device and then releasing it. It's almost like when the space shuttle goes up and it gets released from the rocket. That's kind of what it feels like when I'm doing it. It's you get it where you want it, you engage it into the heart, and it has a little tether on it, and then you cut it's like a dental floss, really long dental floss. You pull your sheath away, you make sure it's adherent. There's little tines on the end, and you tug on it to make sure the tines are engaged, so you'll see them open and close. And then,
it's almost like little fishing hooks that are coming out of the end of it. Is that what you connect into the heart tissue?
Yeah. So so we it goes into the septum, which is the wall between the right ventricle and the left ventricle, and there's trabeculae in there, which are little muscular strands, and you try and hook in there. And if you don't have at least 2 of those tines engaged, then you're not going to get good electrical connection to the tissue. And so we do that to make sure that we're going to have good thresholds, good sensing, so that we can get the most longevity out of the device, and we don't want the device to dislodge. And so that's the part that's exciting when you see that they're moving. And then you cut that dental floss and gently pull it out, and you can feel the heart beating on the dental floss as you're pulling it out, which is so cool.
Yeah.
It's just, I just love physiology, and I love what I do. And because I had the surgical scrub tech feel it also, and definitely deer in headlight eyes for sure.
I mean, this is what you've studied your whole life basically in school, and now this is putting it into practice, that you're really kind of fixing someone's heart.
Yeah, and to see the recovery was so quick. You don't have restrictions with your arm. We'd have people not lift more than about 5 pounds just because of the groin access is large. But I've seen these people back now, and all 3 feel amazing. And to see them recover so quickly, to get their quality of life back so quickly. This is why I do what I do.
And they had it done last Thursday.
Yeah.
So it's been just over a week.
Yeah.
And they've recovered that quickly.
Yes.
That's crazy.
Yeah.
This technology, how long has it been around? And it hasn't been widely available for as long as it's been out, right?
Correct. I think in Iowa in particular, most of these are done by electrophysiologists. I think in some states, interventional cardiologists are doing it. In fact, in my training, I saw two of my old partners from California in the training who were, one was an invasive non-interventional cardiologist and the other was an interventionalist. I think electrophysiologists have a more unique understanding of electrical devices and technology. So I think in the state, there aren't a lot of electrophysiologists, so that limits access. And then having hospitals that have the capability to do it limits access. I would say the technology's probably been developed for almost a decade. In Iowa, I would say it's probably been here 2 or 3 years. I'd have to verify that. It's becoming more widely available, I think, as more people are getting trained. I would say I was one of the later people to get trained only because I wasn't sure where I would be able to utilize the skill set. I didn't want to get trained and then not do it and then have to train again.
Those skills need to stay sharp.
Yes.
Yeah, it's interesting because how big of a leap is this, in your opinion, over regular pacemaker technology?
It's huge, and it's going to change how we do things. As electrophysiologists, we try to preserve the vascular system of the body as much as we can. And when you have wires in your blood vessels, over time, you can get scarring. The vessels can occlude. If the lead breaks, which can happen under the collarbone, it's rubbing under there. People who are active can hit fractures, or if you're in an accident, you can get a fracture. And all of these things lead to complications, and the pacemaker pocket can get infected. Every time you go in the pocket, there's a risk of infection. So it takes the potential for complications down significantly. And the technology is getting there where you'll be able to safely pace in the upper chamber and the bottom chamber. How that will work with defibrillator technology is to be determined. Artificial intelligence and engineering, I think, is helping to make these devices smarter, being able to detect movement to help keep the heart synchronized. And battery technology is better. I mean, the fact that this tiny little thing has a computer in there that's able to self-adjust to your heart cycle is incredible. I'm not an engineer, so I can't really speak. I could ask my husband, but I can't really speak to what happens in that little device. It's extraordinary.
I bet you and your husband have incredible conversations. He's an engineer, right?
Yes, he is.
and you're an electrophysiologist. So this, as far as pacemakers go, the pocket you mentioned, the outside battery and things, that can't be fun to have that. You've always got to be conscious and aware of that, right? This takes that away.
It does. I think that the pocket itself, generally, you shouldn't even feel it or notice it. It is cosmetically less appealing. And so and always a source of potential infection. I think that to have something that you don't have to worry about is amazing. And these are MRI compatible as well as our current pacemakers. I think defibrillator technology is where we have to have a bigger leap. Those devices have to deliver a shock. They're generally bigger, but I have faith that in the next decade, we're going to see a lot of changes. I
was going to say, how long before that is possible in something this size?
Oh, I don't know. I'm not in the high enough pay scale in the know on those. I know the engineers are always working. I think the engineers that work in device companies are really special people. They are so creative and always looking to make things better and safer and smaller and last longer. And so I think the future is, who knows what's going to happen. I think anything can happen.
How many patients do you see a year that are going to need this type of technology? Are there always new patients coming in, or is it a smaller part of the population or patient care that you see?
I think the way I've changed how I look at things is when I see a patient who needs a pacemaker, the first thing I now think of is this a good candidate for a Micra, the leadless pacemaker? And the reason for that is it's good for anyone who doesn't need to pace in the upper chamber of the atrium. So patients who have heart block where the top chamber is beating and it's not conducting down to the bottom chamber, those are perfect patients. Patients who have atrial fibrillation all the time, who have slow heart rates, also perfect patients. So unless you need support in the atrium or the sinus node, I don't see why I wouldn't put in a Micra.
The patients that you implanted it in last Thursday, did they go from regular pacemakers to this?
One did. The other two didn't have any pacemakers. And the one that did was a unique situation. If you have a pacemaker and you pace in the ventricle, the right ventricle, a lot of the time, it can weaken the heart muscle depending on the location of the lead. And what we have known as electrophysiologists for a long time is that pacing at the apex or the tip of the right ventricle is the worst place to pace because it can cause a cardiomyopathy. Particularly in older Caucasian men is the population where that happens most frequently. And this patient had a pacemaker placed elsewhere, out of state, who over time developed a weakened heart muscle. And also, when we tried to upgrade to a resynchronization therapy or a BiV device, both of the veins under the collarbone were occluded. So there was no option other than to have a surgeon place a lead on the outside.
There was no access to the heart.
There was no access. And so this was unique in that I thought, well, we can put this in and pace in a much better place. And statistically, the heart function should improve just with doing that alone. It's a little bit of MacGyver. And the cool thing about this is that the pacemaker that was in this patient was not pacing in the upper chamber. So that's why this was a good option, because they only needed pacing in the bottom chamber. So what we did is we changed the mode in the old pacemaker just as backup to pace in the upper chamber in case the heart rate ever got slow, and then put in the Micra. The great thing about this was that the old pacemaker is still seeing the heart. So
you left the old pacemaker in.
I left it in as a backup just in case. But we could see from the old pacemaker what the Micra was doing. And so the old pacemaker is showing the heart beating, so it senses the heartbeat. So it'll sense the atrium, sense the ventricle. And so once we turned on the Micra, it was sensing that the patient was having a heartbeat on their own, essentially. So the Micra was working well to sense the atrium contracting and pacing the ventricle in synchrony. And so we could prove that because the other device was showing us that it was working perfectly. It was just the coolest thing. Mm-hmm. And this patient is already in a week feeling much better.
I was going to say, it's interesting because you can follow both scenarios now where
Yes.
it's new to that patient and it's a changeover for a couple of other patients.
Yes.
That's probably going to tell you a lot in the future going forward. Not that you probably don't know already from other research, I would assume.
Yeah. Okay. I think the incidence of a weakened heart muscle with a Micra is less than 5%. It's probably 2%. In traditional pacemakers, that's much higher. So we know that if you're pacing in the bottom chamber more than 40% of the time, your chances of developing a weakened heart muscle are pretty good. And so we now have left bundle pacing, which is also a technology that I do here in Carroll to try and pace in the conduction system of the heart. So we do that here to try and reduce that incidence.
So what are the potential hazards of this procedure? I mean, it's got to be pretty intense in the operating room for you, I would assume.
Yes.
It's got to take nerves of steel, I would think. But what are some of the potential issues that you could see with this procedure? I'll take it step by step, because that's how I go through it in my brain. So the first is getting access into the vein. So I use ultrasound so I can visualize the vein and the needle going in the vein to minimize any damage. The artery in the vein. Now, by the way, when you say needle, you're putting something fairly good sized into that vein, right? Eventually, yeah. It's about, I call it a garden hose. I don't know if it's really that big. It's a 27 French. I don't know. Garden hose sounds pretty big. That's what it feels like to me. It's big and it's long and I have T-Rex arms, so it's like hard. I'm glad there's someone else at the table with me. Mm-hmm. So the artery and vein and the groin sit next to each other. So when I was in training, we didn't use ultrasound, and there's a chance that when you're trying to get in the vein, you can also get into the artery and cause a connection between the two called a pseudoaneurysm. So having ultrasound guidance helps reduce that risk significantly. We use X-ray to get the wire up
through the heart towards the collarbone into the superior vena cava. And that's how we stabilize the delivery system going into the heart. And then we gradually dilate up the vein to accommodate the large sheath. We do use stitches. I put 2 stitches in the vein to help close it once we get everything out. So the risk is damage to the vessel. You're watching as you're putting this sheath up into the heart to make sure you're not poking through a vein in the belly. I mean, you're really just going very slowly and very carefully. Once you're in the heart, then we take that wire out and then we bring the microsystem, the delivery system in. And you're looking on x-ray, so you're going across the tricuspid valve from the right atrium into the right ventricle. So at that point, you're worried about poking a hole through the heart with the delivery system. And so Medtronic did change the delivery system a couple of years ago to make it safer. It used to be a little, I don't want to say pokier, but the edges are a little more rounded now. And they've kind of dispersed how much energy is on the cup that we deliver with. So the risk of poking a hole through the heart is a lot less. So that made me feel better about bringing the technology here. And then once we get the location, then we deliver the micra and then just making sure it's engaged so it could dislodge. So the risks are vascular damage, poking a hole through the heart, death. Infection, in theory, although the rates are much lower than with traditional pacemakers. I was afraid about having to redeploy a device, but I did do that on Thursday as well. We had a location that wasn't ideal and I had to recapture the device and redeploy it. And I was afraid about doing that. It was fine. I think my fears are much worse than reality.
That's referred to as a little hiccup in the procedure, right?
Well, it happens even with transvenous pacemakers. You don't always find a spot the first time that's great, and you have to relocate it. The difference is I've been doing the other pacemakers for 25 years at this point. This is like, I've done half a dozen now. So the nervous level is a little bit higher. But it went great. Yeah. I mean, I think as long as you are slow and methodical and everyone is communicating, things will go fine. And that's always been my strategy.
How vastly different are the two procedures from the old pacemaker to this one? It sounds big.
It's huge. It's a totally different access. So you're working from the groin instead of up in the chest, which gives anesthesia a lot more room. Now I'm not like cramping their style anymore. There's not really any surgery where you don't have to create a pocket. You don't have to sew anything down. I mean, it's really just one move and that's it.
Once you've got access to the vein,
that's it.
That's it.
And it's just taking your time and finding a good spot.
So how many people are involved in this procedure? How many people do you have to have in the operating room?
It's the same as a traditional pacemaker. So you have the anesthesia provider, you have a surgical nurse in the OR, you have a scrub tech, you have myself, you have the radiology technician, and you have the device rep.
And how long does this procedure last? It's not a long procedure, is it?
No, I think the more I do, the shorter it'll get. I think actually on Thursday, from the first case to the last case, the procedure time went down significantly. So a traditional pacemaker, I would say, takes about an hour or hour and a half at the most. The first one took an hour and a half, and I think the last couple were 30, 45 minutes.
Wow.
Yeah.
That quickly.
Yeah.
Like I said, when I had my stent put in, that was 45 minutes from the time they wheeled me in to the time they wheeled me out.
Yeah.
So this is really kind of the same thing, but they're very different procedures, obviously.
Yeah.
Wow. Is there anything else that, you know about this procedure that people should know about before when they listen to this, what they should know about this?
I think for St. Anthony and for our community that listens to this radio station, I think a lot of people think they need to go to the big city to get certain procedures done. And I really want to get the word out that we have a lot to offer in our community and in our hospital. And we have bigger systems. We have Mercity, we have Trinity, Unity Point. I would say, especially our communities that are northwest of here that tend to go to a bigger city than Carroll, those technologies don't even exist. You cannot go to Fort Dodge and get a pacemaker right now.
Not at all.
Not at all. So coming here and knowing that these exist, so I'm trying to reach out to my colleagues who work in Loring and who are in some of the other communities. We had One of the patients that we did last week came from Manning, who happened to be in the hospital with a slow heart rate, and they called up here. So we can definitely get patients in a lot faster than you can at some of the bigger hospitals in the bigger cities. And just knowing that that exists, knowing that we have the technology, the capability to do that, I think it makes our hospital certainly different than some of the other smaller hospitals in our community. And it's better for the patients to be local, in my opinion. And I know for some reason now it's taboo to talk about disparities in care and inclusion. But to work in a rural community, we don't have a lot of the resources. Our patients don't have resources. There's transportation involved in trying to get to these larger hospitals. So if we can do it here, why wouldn't we? Why wouldn't we give things to people locally that they deserve to have? And that's been my passion since I moved here. I started this device program in 2014. I want to continue to grow it, and I want to spread the word. Our patients deserve this.
How big of a risk is this for St. Anthony's? They could have said no, right?
Yeah, they could have.
They could have said, no, we're not going to get involved.
I'm very convincing. I think I appealed.
Did it take convincing from you for them to say yes?
A little. I mean, it took convincing for me to bring pacemakers here. I think everyone's excited, and it's a cautious excitement. And I think that if I had proposed this day one, maybe not. Mm-hmm. I think I've proven that I have good outcomes, that I'm safe, and I think that they trust me. And so I think that's the reason why they were okay with it. There was a lot of nervous energy last Thursday. I'll say that. And, I brought in treats to help bring the level down. And you have to lead with calmness and confidence so that everyone believes in you. And I think that I've proven that we can do great things here.
I can tell you personally, I've talked to many nurses, many doctors. You are very well respected here in this hospital. So, where is this just the start of other things that you could possibly do?
Yeah. So the latest.
Look at me. I'm already going, what's next?
Yeah, well, there is. And I'm excited. It's just trying to figure out how I'm going to get it here. So there is another cool technology that's called an extravascular ICD. So the defibrillator lead goes under the sternum. And the device kind of goes on the side of the chest. So again, not using the vasculature. Right now, you have to be trained with a cardiothoracic surgeon because it is a space that we're not familiar with. So in my brain, I'm conniving about if I could get one of our surgeons to come up here, do a few cases with me, and then maybe bring that technology to Carroll as well.
Well, it is very, very exciting technology that's here right now. And again, only available in either you got to go to a big metro area or Carroll.
Yeah. So right now in Des Moines, Mercy and Methodist are doing it. Mary Greeley, I do them there. So Mary Greeley does them when I'm there.
You are their resource for this.
Yes.
Yes.
Yeah. And then it looks like Waterloo at Mercy, Mercy Cedar Rapids, University of Iowa, St. Luke's in Allen, and Mercy Genesis in Quad Cities. And they just did their first one this week. So these are all larger hospital systems. And so to that list, we have now added St. Anthony.
That is pretty exciting stuff. When you involve that with the cancer center and everything else that St. Anthony's does here for a hospital in a town the size of 10,000, it's pretty amazing stuff. So
I'm very proud to work here.
Absolutely. I think so. And you were right. When you texted me last Friday, I said, this is super exciting and we need to get the word out. I guess who is a patient for pacemakers, or if they're having heart issues, we would be remiss if we didn't get that message out too. If you're experiencing something, what do they need to come in when they're experiencing something? So
traditionally, pacemakers are for patients who have a slow heart rate and who are symptomatic with the slow heart rate. So the key is having symptoms. There are a lot of athletes who have heart rates in the 40s. It doesn't mean you need a pacemaker. It's only if you have symptoms. And then there are different reasons why you have slow heart rate. So the symptoms would be fatigue, dizziness, passing out, sometimes swelling. And our primary care in the community is very good about referring those patients to me. A lot of times I'll get monitors, Holter monitors or vent monitors that I'll read and see something suggestive of the need for a pacemaker. And then I'll reach out to the referring provider or physician to say, hey, what symptoms are these patients having? They may need a pacemaker. So generally they get referred to me, and then we determine whether or not a pacemaker is needed.
Now, if somebody already has a pacemaker, I don't want to put it in like it's buying a car, but maybe you want to upgrade to this, or is that even a thing?
Not really.
They have to be having issues, I would assume, to change what they're doing now. If what's working is working right now, they stick with it.
Correct. And again, if you need pacing in the atrium, this wouldn't be the device for you. So there still is a huge indication for traditional pacemakers. I would say we generally don't switch unless for the one case that we had last week where that was our only option. Mm-hmm. There was nothing that we could do, and this was the one thing that could improve the heart function and the quality of life. I think generally if you have something, we stick with it.
That kind of sounds like it saved their lives.
I'm hoping. We'll see. Yeah. Time will tell.
Okay.
Time will tell.
But if they didn't have any other options and this became a great option for them.
Yes. And I think already that person is feeling better. Sometimes you worry about placebo effect, but I noticed that the blood pressure got better immediately once we put that in. Their color, their perfusion looked a lot better. I'm hopeful that it will reverse the causes that the pacemaker contributed to the weakening of the heart muscle. I'm hopeful that it will get better. And if it does, I'm hoping to write it up.
Yeah, absolutely. So not only do they need to trust their hospital and all that, they need to trust their doctor, right? So we're going to find out about you right now. We're going to turn the subject over to you. Boy. You told me last time you grew up in New York.
I did.
Talk about that. Growing up in New York, I know you left for Florida. Your dad retired. He was a New York City police officer, he said. What was it like to grow up in New York? You grew up in where?
I grew up in Flushing, Queens.
Flushing? My dad is from Flushing.
Really?
Yeah.
Nice.
It was pre-World War II, but it's changed a little bit. But what was it like for you growing up there?
I loved it. I have great memories of childhood. We grew up in a cul-de-sac. It was garden apartments, so we lived on the top floor. Someone lived on the bottom. Our elementary school, I'm still friends with my friends from kindergarten. So we were I don't know if they were doing a new program at our school, but the kids in my class, we were from kindergarten to sixth grade, all stayed in the same class. And we had a classroom, and it was called the Dome. And it was a very open area. And I just really have fond memories. My mom would do arts and crafts after school. We would have a street fair. Mr. Softy would come by. It was a very good childhood. It was very diverse, which I miss. I think the one thing I miss is the diversity that I had growing up in New York.
Yeah.
And I miss all the food, being able to walk places. What I don't miss is the crowding and the noise and the traffic. What I love about here is nature, having open spaces, the quiet, being able to see the Milky Way. That was my requirement for moving. I wanted to be able to see the Milky Way at night, not to have so much light pollution. I
guess we take some of that for granted here in this area. But it's interesting. Everybody talks about growing up here. Oh, yeah, they disappeared once the sun came up. And then, mom called you and you had to come back when the streetlights came on.
That's the same.
Was the same?
We got kicked out, and said, come back. The great thing was we just rode our bikes and went around and hung out at friends' houses. A lot of, I think, pretty similar to here. My friends' moms were like my second moms. You go over to someone's house, have lunch, then they come over to your house. I mean, it was great. Yeah,
my dad said the same thing. He stood in line for everything. He never missed that. He was like, I love the fact that I don't have to do that in the Midwest. But when did you move away? You said your dad retired. He was a New York City police officer.
My senior year of high school.
That had to be interesting to have a dad who was a New York City police officer.
Well, I wasn't allowed to do anything. So it was a very strict household. My dad saw all the bad in the world. And so I grew up relatively sheltered. And then my dad retired my senior year of high school. We moved the end of my junior year. There was a stabbing at my high school, and that was, I think, this final straw for my dad. They were putting in the metal detectors. So we moved my senior year of high school to Florida, which was hard, very hard. I was captain of the gymnastics team. I quit that, didn't know anyone at the school. And then the New York school system and the Florida school system is different. And I was bright. So then you come in and all of these people who have been going to school and are ranked, then this new girl comes in and has changed the ranking.
Uh-oh.
And so I wasn't real well received.
You didn't make friends with the top
No,
kids,
not with the nerd group that I was a part of, no.
How big was your high school in New York?
It was 4,000 or 5,000 students.
Wow. Nobody around here has any idea of how big that is. So you moved to Florida. Where'd you go to there?
We moved to Sunrise, which is near Fort Lauderdale.
And completely 180-degree difference, or was it, a bigger area as well?
It was very different. Florida was warm and green, and I feel like our dollar went a lot farther. So it was the first time we had a house. It was the first time I had my own room. So it was just different. I had got a car. It was amazing. It was definitely a step up for our family as far as economic status. I went to the University of Florida only because it sounded nice. I didn't really know anything about it. I'm a diehard Gator fan. I spent undergrad.
Hey, national champions, right?
Yes. I won that bracket.
I forgot to ask you about your family. Who else in your family? Your mom, your dad? What are their names?
Stephen and Laura. My mom wasn't a nurse and then stopped nursing as soon as she had children. So she was a stay-at-home mom, which was great. She made our clothes, made our food. I remember homemade bread. Just very fond memories. My dad, even though he worked nights, would always come to my gymnastics meets. And then my sister, Joanne, she's an admiral in the Coast Guard. So underachievers in our family.
Yeah, I guess.
Yeah.
You guys need to pick it up.
I know. And then I have a half brother, Jay, who is in Florida as well.
So you went to the University of Florida. You did medical school there too, right?
I did, and residency and fellowship.
And so what was that like to go through medical school? You always see the television shows, things like that. I asked Gina Bading, who's an appeals court judge, I said, we all know that law school on TV is different than law school in real life. So what was the difference between the two?
It was hard. So I was one of the younger students in the class. So I applied for an honors program, which I did undergrad and med school in 7 years instead of 8. So I was one of the younger students.
Yeah.
And so I think for medical school, most of us have been used to being one of the smartest kids in the class. And then you're full of a whole classroom of the smart kids. So that was really a difficult adjustment and actually having to study. And so medical school was a lot of long hours in the library. I just remember living back when we had like textbooks. Nothing's online anymore.
Yeah.
Or wasn't back then. We didn't have. I
didn't
can't
carry
even remember
a laptop
when
back then.
No, and I don't even remember having a cell phone. I must have at some point in there, but it was just a lot of studying in groups, late nights. I remember the anatomy lab. It's just fascinating. It was intimidating. It was a lot of growth.
Did you always want to do medical school? Was that it?
No, when I was younger, I wanted to be a psychologist, which is actually a lot of medicine too, is psychology. I did Psych 101 and I just was like, wow, this feels like common sense to me. I'm not sure I'm going to get anything out of this for me. Mm-hmm. And then I was living in the honors dorm and there were kids applying for this program, for this 7-year medical program. And one of the students told me I was too stupid to get in. So that's actually how I got into med school, because I was like, oh, really? I'll show you. And so I applied for this program.
Don't challenge the underachieving family that has all of these great things going on. So
yeah,
that's all they had to do was just challenge you, right?
Yeah. And then, when I wasn't sure if I wanted to be a surgeon or not, and my advisor, who I'm still friends with, Dr. Gonzalez-Rothi, was a pulmonologist, and he just said, you can do a year of surgery, and if you don't like it, then go do internal medicine. If you do a year of internal medicine and don't like it and do surgery, that year of medicine will always serve you, because internal medicine is used in just about every specialty. And so that's how I chose the internal medicine route instead of the surgeon route. And I wanted to have a relationship with patients. I enjoy procedures and also wanted to have caring for people for years and years and years. So cardiology was the best fit for that.
You eventually wind up in California, right?
Yes.
How did you get there?
Oh, man. So I did all my training in Florida, and I have Raynaud's, which is where your fingers in the cold, your fingers and toes turn white and blue. Oh. And so I wanted to go somewhere with warm weather. Mm-hmm. And I didn't want to stay in Florida. I had actually been married very briefly, and my ex-husband was still in Gainesville, and I just wanted to get as far away as possible.
California ought to do it.
Yeah, so I didn't know anyone there, and I had a Honda S2000 and just drove out there and found a job. One of the device companies found me a job, And I moved out there, and then that's where I met Ken.
Did you have the job before you moved
I
out?
did.
Okay.
I did.
All right.
I did.
I thought you're driving out there with no job and like, this is where I'm going to head.
Well, it was, I was very poor from training. And so I found the cheapest moving company I could. So I moved with only what I could fit in the trunk of an S2000, which is not a lot. And then the moving company stole all of my belongings. So
what?
Yeah. So like I showed up for orientation for my new job and I didn't have any professional clothes. I just had like shorts. And so the office manager, who's still a good friend of mine, Casey, she loaned me money so I could go shopping to have clothes for my first week of work until
Bit of
I
an
could get
awkward start there.
paycheck. Yeah.
So where was it in California?
I was in Orange County.
Los Angeles.
South of, it's between LA and San Diego, actually. So I worked in Saddleback Memorial Hospital. Originally, I worked at St. Joe's in Orange County. So I had quite a few jobs out there.
So your husband, who is from Carroll,
Yes.
that's the connection here. You meet him out there in California and you get married. And you probably had never heard of Carroll, Iowa, obviously.
No, we met on Yahoo Personals, which doesn't even exist anymore, and hit it off right away.
So it's just hard to meet people, and it probably was fairly new back then, right?
Yes, it was really taboo, actually.
Was it?
Yeah, now it's like very mainstream, but back then, very tabooed online date. But the only people I met were at work, and I certainly didn't want to date anyone in the medical field. I get enough of that all day long. And so, yeah. When we would come to visit for holidays, I just loved it here. I really did. And actually, a funny story, when we were moving here, Ken got a map out and said, "Where is Iowa?" I just kind of made a circle around the Midwest. I was like, somewhere here. So honestly, I didn't even know where Iowa was on a map when we moved here. In New York, you just learn the coast and geography. I mean, I blame it on my education.
Yeah. I totally get that. And I believe that because I moved to Denver, Colorado when I was 18, 19 years old. And somebody said, I'm from South Dakota. And they looked at me and said, "What state is that in?" I'm like, "You've got to be kidding me, right?" So you had a daughter?
Yes.
How old is your daughter?
She just turned 15 on the 15th.
All right. Yeah. So does she have the car?
Not yet.
Not yet.
No, we have to actually take the test first.
Okay.
So we can do driver's ed.
So what was the change like to go from sunny California to Iowa? You don't like the cold. We established that.
I've enjoyed it. So what I didn't realize in California, every day is pretty much the same. And so having the seasons has been really nice. I enjoy, like now in spring, watching flowers start to bloom. The grass is getting green. You have the little robins are back. When you see a robin, it's so exciting. Having that first big snow and just like it, I enjoy it. I really love it. I think for me, the challenge has really been making friends. I think as someone who's older, not from here, who's the cardiologist in town, I think it's lonely. I would say that's really the only downside. However, it's brought me so much closer to my husband and my children, and I just appreciate things a lot more living here that you take for granted elsewhere.
So what do you do outside of work when you want to get away from all the stuff that happens around here? Because I assume, like everybody else, you take your work home with you. Patients, things like that. You're thinking about it a lot.
Yes. I try to, well, I'm usually here till about 7 or 8 o'clock at night and then back at 7 in the morning. So there's not a lot to take home because I leave it all here.
So it's 12, 13 hours a day.
It is. And I'm a big baker. So I love baking. That brings me joy. And then...
What's your specialty?
Ooh, my son would say chocolate chip cookies.
Okay, you have a son too. I thought it was just a dog.
Oh, no,
okay.
yeah. So he happened after drinking Carroll water. I ended up getting pregnant.
I'm going to have to ask about what does that mean?
Well, Carroll is a fertile community. I don't know if you haven't noticed that. I had him, oh gosh, how old was I? I was 43 when I had him. So wasn't really planning for another one. And then, you drink the water here and boom, you're pregnant. And
all right. That's how that works, people.
Sawyer, he's 9. He's just our little Buddha. He's just a happy little guy.
Yeah.
So he would say chocolate chip cookies and chocolate chip pancakes are his favorite things. My husband does the sourdough. That like the COVID thing has stayed. So we have a lot of carbs in our house. And then during COVID, we had a basement gym, and that really grew during COVID. So I have an online coach, and so I exercise. For all the patients who ask me, why am I so thin? It's because I exercise most days of the week.
You handle the carbs very well. So you're biking also.
I
you
do
love to bike.
love. That's how we first met many years ago.
And I do remember that it was a coffee truck that was outside of Denison.
Yeah.
Okay.
Yeah, that's where we met.
Yeah.
And so, yes, I love cycling. We did that a lot in California. And so I'm excited to get back on the trail. You know, the wind is the thing here. Mm-hmm. It's great one way and always the way home. Or sometimes the wind shifts and you get the wind in both directions, which I don't understand.
Yes, there's many days I've bet that the wind is in your face both ways that you're going on there. As we kind of wrap things up here, if you were not a doctor, what would you be doing, do you think?
I think I would be a teacher.
Would you? Of what?
I don't know. I think science probably, that would make the most sense. But
like high school and college or more?
No, I think I personally would probably do elementary school. I'm not sure I'm strong enough for middle school, but really just to get that spark of the interest in science going. I think the younger you get exposed to it, the better it is. I think eventually, like, my goal is when I find free time, my dream would actually be to go into the local schools and do either a dissection or do some kind of a fair where people see what we do, because it's not just about being a doctor. I know we have a lot of recruitment for nurses. It's not even nursing. It's technicians, sonographers. I mean, there are so many cool things that you can do in medicine that outside of being a doctor. Doing a phlebotomist. I mean, just the human body is so amazing and so miraculous. And to just get kids interested in that would be really cool.
That kind of leads into my next question. What do people get wrong about doctors? What do they just assume?
They assume
that stereotypes, things like that.
I think they assume we're like really loaded and we're in the pocket of pharmaceuticals, and that we do things to make a buck. And I would say that is the most hurtful misconception, especially knowing all the other physicians in this community. We do it for the love of caring for people. We do it to improve quality of life. We do it to improve health. And to insinuate that we do things to make a quick buck is so insulting. We gave up our 20s to study. We gave up as women, we gave up our reproductive years. A lot of women physicians struggle with infertility because you sacrifice that to study medicine. As I would say, loss probably similar. And so to belittle that, I think, is the most hurtful misconception. And it's become so much more prevalent, especially since COVID, and just a lack of trust in our education and our decision-making is a thing I find the most infuriating, actually.
Last thing I got for you. What's some advice you'd give somebody who wants to be in medicine?
Study hard. I think whatever you want to do in life, if you're passionate about it and you believe in it, keep going. Even if someone tells you no, that's their no, that's not your no. Anything that you believe in and you put your mind to, you will achieve.
So would you push your kids towards a career in medicine, or?
I don't know. I think if it's their passion, sure. I think medicine is so different from when I started to where it is now. It's become a factory in a way. I think that it has shifted from patient-focused care to financially motivated care from the top down. And so I think the misconception also out there is that the doctors are the ones making these decisions and choices, and it's not us. It's insurance, it's legislators, it is hospital administrators. And I think small hospitals like St. Anthony are the ones that are suffering, trying to stay afloat. St. Anthony is one of the few hospitals that's been able to not be bought up by a big system, which is an amazing thing. It gives us autonomy as physicians that we don't get elsewhere. And if you have that little dollar that you want to donate to St. Anthony's, I would say do it, because we need the community to keep us open.
They do a lot of great things here, a lot of things right.
And they don't employ me. So I'm saying that
Yeah.
out of my own belief of what the community needs. I'm employed by Mercy, which is going to be Trinity, and I'm very fortunate that they let me stay here, because I think I do a lot of good here.
I know that you've dabbled a little bit in social media and doing some like podcasting stuff. You should do more of this. I mean, you're really good at it.
Well, thank you.
So,
in my free time, I'll find a way.
Outside of the 13-hour days, I'm sure you can find a few
I find
hours
it
to
intimidating
dedicate.
to really put myself out there like that. I think I have a lot to say, and I think my goal would be to educate patients. With the way social media is right now, my hesitancy is hate. I think it's so easy for someone to be hateful on social media that I don't really need that in my life, honestly.
No matter what you say, somebody's going to disagree with you and disagree with you vehemently.
Yes.
And and it's nothing you can control. But it's been fun.
Yeah.
Thanks so much for texting me and telling me about the procedure and stuff. And we're going to try to get the word out even more. But I'd love to hear more from you in the future.
I love it. I'm excited about what I do. I love what I do. And I was really stoked that you agreed. So thank you.
Absolutely. Dr. Suzanne Feigofsky joining us here on Must Know People.